el programa combinado Tulane LSU en Nueva Orleans. Ella era antes que yo un poquito, ella salió y yo entré al fellow. Después se fue para su país un tiempo, dos años, y por fuera estuvo en una isla del sudeste asiático, en Guam, y después regresó a los Estados Unidos. Está trabajando en Jacksonville, Florida, con la Universidad de la Florida. Ella trabaja como especialista en infectología, pero también es la directora del programa de pediatría de residencia de la universidad en Jacksonville. Ella está siempre con residentes de pediatría, de modo que la idea es que nos va a acompañar para participar con un caso clínico de Ayesha. I read it in Spanish and then...
That's okay. I understand some words. I can figure it out.
Ella va a hacer la charla, la presentación del caso en inglés. Esperamos que participen porque quiere que digamos, pregunten, o cuando haya momento de hacer el diagnóstico diferencial, pues participen, no les dé pena. Si quieren hacerlo en español, yo se los traduzco, pero el que se sienta tranquilo de hablar en inglés, porque sé que varios hablan inglés bien, no hay ningún problema. La idea es que lo hagamos bien. Ayesha, welcome to Colombia.
Thank you. Okay, so good morning. I apologize, I don't speak Spanish. So you have to put up with me talking in English. If I'm talking too fast or you don't understand, just raise your hand. And Dr. Alvarez will kindly translate. But it should, I think there are a lot of similar words in English and Spanish, so I think you can figure out most of the stuff. So thank you for having me. I'm also, I see a lot of trainees, like Dr. Alvarez said, I'm also a residency program director like you. I also have, we take 13 residents a year. One pediatric neurology, there's pediatrics, and then goes on to do neurology, and the rest straight pediatrics. So I'm very used to having trainees, and we have a fellowship program. And over the last 2 years, we have developed a collaboration. So if you work with Dr. Alvarez, maybe she'll send you to come and spend some time with us. I have sent 2 of my residents here in the last year. Some of you may remember, some of you are new, so you may not know. So I just want to know, because this is a pediatric ID case, and we chose the case because it may be something you may not see so frequently here. This is not something that is sort of endemic here in Colombia, but of course you have a lot of travelers and you have a lot of Colombians who live in the US and who may be traveling here, and so this is something you may see. And it's one of those things that you have to be thinking about, otherwise you will never never come to the diagnosis unless it's something you're thinking about. So we just thought it would be interesting. So ask questions. So I know you're not falling asleep and you're listening. Yeah. So how many interns? Just raise. So I know how many are brand new. Okay. And how many second year residents? Any? No? Yes?
Ayesha, interns here is the last year of
last year of
medical school, and interns from American point of view is the first year residence.
Oh, so intern is first year resident, yeah? So then, yeah, so which is the same for us?
No, but intern here is last year of the medical school.
Oh, intern is also the students, just students.
Yes.
Okay. And then the first year of residency is what?
It's first year.
First year. Okay, so how many first year residents? Okay. And second year? And third year? How many years of residency do you have? 3 years or 4 years?
3 years.
3 years.
But most of the first years are outside in other rotations.
I see. Okay. And then how many PhD fellows?
See what's coming.
Okay. And then faculty.
The faculty.
Okay. Okay? Alright. So how do I move the thing?
Okay.
I move it or you're going to move it?
I no
But I can move it. It doesn't matter. Oh, fine. Just from there?
Yes.
Okay.
You want?
Yeah, up and down, right? Yeah, that's fine. Yeah. Okay. It's good. I mean, I can just move it. Alright. Okay. Alright. So, I feel funny because when we do our conferences, we sit together. So I kind of feel funny standing here talking to you, but that's okay. So the case I'm presenting, this is a case that I saw. I was on service. The 6-year-old boy who came had fever, a rash, and abdominal pain. If you don't understand any words, please raise your hand, okay? Because if you don't understand, then it won't be any fun. So when he came to us, he was healthy, no past medical history, never been sick, was having fever for 6 days. Maximum, I don't know, do you use centigrade or Fahrenheit? But I put both. So 40 degrees Celsius for the last 6 days, and he was having some vomiting, off and on, and also a lot of pain in the stomach, crampy abdominal pain. So that's why he went to the outside hospital. Ours is a bigger referral hospital, just like your hospital here. So from the outside hospital, he was transferred to our hospital because the concern was that maybe this was something like a surgical abdomen. Maybe he needed surgery because having a lot of pain. So when he came, this was his initial presentation in the emergency room, kind of similar also by the time I saw him, but he was still having fever, didn't look well, very ill appearing, had the conjunctivitis, non-exudative. So just the eyes were red, but there was no discharge. Had some lymphadenopathy on both sides, nothing very big, nothing. I know you see a lot of TB here, but this wasn't anything that would make you think of TB. And a lot of pain, a lot of abdominal pain in the right upper quadrant. He had rebound, he had guarding, so everybody in the emergency room thought that, this was a surgical abdomen. Also had a rash, and I'll show you pictures of the rash, but it was diffuse, meaning all over. He kind of looked red, and it was blanching. So when you pressed it, it would disappear, and then it would appear again. No petechiae. When he had the high fever, he looked really red. He was very fair, so his cheeks looked really red, his skin looked really red. Really, the rest of the exam was normal. There were no respiratory findings, no cardiovascular findings. He didn't really have any significant edema of the extremities, maybe a little bit on the feet, but not much. And so first year he came, the surgeons were called because they were thinking maybe he has appendicitis. And so they came and they checked him, and they couldn't really tell whether or not he had appendicitis or not. So they admitted him to the hospital for observation. And they did some basic lab tests that I'll share with you. So he had a white blood count, 2800, mostly neutrophils, and then a mix of the others, 11% band. So obviously his marrow was stressed. Hemoglobin was 11.4, platelets you can see on the low side, 61, and then of course his liver function tests were elevated ALT, elevated AST, and because of the concern for appendicitis, they did a CT scan in the emergency room, and it showed that the appendix was dilated. It looked a little big. There was some edema around it, and then there was a small little stone there. But nothing that they felt that they had to rush in and do surgery. So that's why they wanted to admit him, manage him medically, and just watch and see whether he's going to get worse or not. All right. So he got admitted, and then over the next 2 days, he kept having abdominal pain, and he still had the rash, and he still had the fever. And so the surgery service just decided they were just going to follow because they still didn't think they needed to operate because it was bad, but it wasn't like, they could control it with Tylenol, etc. And they just didn't think he needed surgery. And then, but what was unusual was that this child still had the rash. And you don't see that with appendicitis. So that's why, the hospitalists, they called us. So that's when I showed up on the scene. So any thoughts?
Questions first, like
Thoughts or differentials? That's what I have on the next slide. Yeah, so okay, Kawasaki, good point. What made you think of Kawasaki?
He has fever, he has the rash, he has the lymphadenopathies.
Yes. Yes, and he has the non-executive conjunctivitis. So yes, so he needs fever, then along with the rash, and then the non-executive conjunctivitis. The lymphadenopathy in Kawasaki is unilateral, large, 1 to 1.5 centimeter. So that's a bit atypical. He's also 6. So it's for the upper end of normal, right? 6 months to 6 years roughly is the typical age. But certainly you can see the more outside the normal age range, the more atypical the presentation, right?
Ayesha, some epidemiology questions. What is the time of the year? Where is he from?
Yeah. So that's very important, right? I mean, yes, of course, you're thinking Kawasaki, which could be anywhere. You said mononucleosis, very appropriate. Yes, absolutely could be. But then, anybody else have any other thoughts for differentials before we talk about epidemiology? Traveling, yeah, so that's part of the history, like where did this child travel? So,
what time of the year
what time? Because again, you're also thinking of other viruses. Doesn't look so typical, but maybe influenza, adenovirus, parvovirus, mycoplasma. A lot of other.
Meningoencephalitis is not
yeah, and then nuclear rigidity. When you gave him Tylenol, the fever came down. He looked better. He still had the abdominal pain, though, but no. Meningeal signs to make us want to do an LP on him. So like Dr. Alvarez mentioned, whenever, for ID, it's very important to know where someone has gone, where they've been, what time of the year it is, etc., etc. So you may not be so familiar with the epidemiology in the US, but these things are important to us. So no travel history. He lives I just realized I should have put a map and shown you where we are, but we are in Florida, so imagine Florida in your head, but we are at the top. So this is Florida, this is Miami, this is Jacksonville. We are very close to Georgia. The whole area where we are is very green. Like here, but even more. Lots of trees, lots of woods, very, very green. Yes. I'm sorry? Rocky Mountain, okay, good, very good thought. So, yeah, very good thought. So, like a tick-borne infection. So, again, and then I will show you the epidemiology. So yeah, we don't have, but our land is mostly flat. No mountains like here, and no mountains like in Colorado and, the central part of the US. It was summertime. So that's important because especially when you're thinking of a tick-borne disease because enterovirus because what happens in the summer? Everybody's outside and everybody's playing. So then you can get bitten by something, right? So that's very important. And then talking about influenza and adenovirus and some of these other viruses, obviously less common in summer. We don't see in summer. In summer, what we see in Florida, we see RSV all year round. That's very different from the rest of the US, where you see RSV in winter. In Florida, very different.
Virus sincicial respiratorio.
Yeah, respiratory syncytial virus. Yeah, so I'm sure you have here.
Yes, all year round, especially during the...
All the time, right? Yeah. So we also all the time, but in most places in the US it's seasonal. It's like in winter time. It's not there. Yeah, maybe we're more like Colombia, who knows? So summertime, outside exposure, and then what's that? Yeah, he didn't. There was no history of camping or traveling, but of course they're out, they're in the woods, they're playing. He lived in Jacksonville, but again, parts of Jacksonville are very, very rural, lots of trees and lots of woods. Parents didn't remember that he had any tick bites or insect exposures. So I think that's you guys came up with a pretty good differential diagnosis. So here, this is not my patient, but because we actually published this case just because it was such an unusual presentation. But this is not him. So this one you can see that you can see the rash, but you can see maybe some petechiae. Our patient didn't have any petechiae, but he just has this diffuse erythema and like a macular, very non-specific rash. This child also has edema, you can see, right? You don't see the landmarks, you see the malleolus, and it's not that well defined. So there's a lot of edema and edema. Our patient didn't have that much, just maybe a little. And then this is also not my patient, but kind of look like that, right? This child doesn't have conjunctivitis, but my patient did. A non-purulent again, you can see the slab cheeks, and it became even redder. What's that? Yeah, parvovirus. Yeah, absolutely. So that's all part of the differential. And so the cheeks look redder when he had fever. So that's basically how he looked. Very non-specific rash. Anyway, so we talked about differentials, we talked about Kawasaki, EBV, enterovirus, adenovirus, parvovirus, rickettsial illness, like Rocky Mountain spotted fever, and what else am I missing? I think mycoplasma to give you a non-specific illness. So all very, very good thoughts. All right, so we did a few other tests were done. We did an ESR, non-specific, but helps you know how much inflammation is going on. Same with CRP, not very elevated, just barely. I don't know if your units are different here.
Yeah, it's the same.
You use milligram per deciliter.
CRP.
That's different?
Yeah, no, it's the same.
It's the same.
Milligram per deciliter.
Okay. Yeah, so very mildly elevated, nothing that makes us excited. Doesn't make an infectious disease physicians very excited because, okay, something's going on, but nothing, nothing that's especially not going on for a long time. So the team had done a rapid strep test, negative, the monospot was negative. Now remember, he's 6 years old, monospot may not be so reliable in a younger age group, more reliable in adolescents. We did a respiratory viral panel. Our respiratory viral panel, they test for adenovirus, human metapneumovirus, and parainfluenza virus. And then we have a separate panel for influenza and RSV, and they were all negative. And then of course the EBV, we did also send serology, and we sent the parvovirus serology. And we did not have these results when I saw the patient because this was of course weekend. And when over a weekend parvovirus we don't do in a hospital, it gets sent out, so it usually takes a week to come back. But anyway, this was later on we got these, they were all negative. So when we saw this patient, and based on physical exam and history, basically I thought of all the different things that all of you thought about. But one thing that we see so again, epidemiology is so important. So we don't see Rocky Mountain spotted fever, but what we do see is ehrlichiosis, which is all.
Any smear in the blood?
Yeah, it's not. No, it wasn't. But that and more seeing, and we'll talk about that. That's very non-specific. may see it in the first week of illness, but it has to be a very experienced technician also to be, and what Dr. Alvarez is talking about, I will show you the blood smear. So anyway, that's what I thought about, because they lived up, he was out, his father said he plays outside a lot, and then the biggest clue is what? The lab test. I showed you the lab test, right? So, let me just go back. So that's what, because all these tick-borne illnesses, whether it's Rocky Mountain spotted fever, ehrlichiosis, anaplasmosis, they're very non-specific when they present. They present like flu. Fever, myalgia, pain, chills. You really can't tell based just on history alone. But the labs are very helpful. So, and this case was atypical because of the abdominal pain. That is not a very common presentation. When we went back and looked, and such severe pain that you call the surgeon thinking it's appendicitis, right? When we look back in the literature, there were only 3 cases that have been reported with such severe, like with abdominal pain as the presenting feature. So this was what made me suspicious. White count is low, so leukopenia, okay, thrombocytopenia, and transaminitis. And I did not put the electrolytes on there, but oftentimes these children can have hyponatremia. Yeah. So when you see that, for you guys, you have a traveler who's coming, maybe from Georgia, Florida, etc. And you see those labs. That's when you think, okay, because you're not going to see this classic pattern made with like influenza or parvovirus. You may see parvovirus affects the red cells, right? So red cell is low hemoglobin, maybe low platelets sometimes. Shouldn't affect the white count so much. May sometimes cause elevated LFTs, but shouldn't cause hyponatremia. So when you see hyponatremia, thrombocytopenia, leukopenia, and then that's, you start thinking about these things.
But Ayesha, in English, but also it's a very good differential diagnosis with Kawasaki with toxic shock syndrome presentation that looks like may have all these things like elevated LFT, thrombocytopenia that is not common in Kawasaki, but
it's a bad prognostic sign. Yeah, but he wasn't toxic because he was admitted in the hospital and we watched him. Initially he presented, but he wasn't, he was sick, but he wasn't toxic, and his vital signs was stable. He would have tachycardia when he had fever, but he was not in the ICU, he was on the floor. So, but yes, absolutely. If he looks sicker, he's also 6 years old, that's something to consider. Okay, so we ordered, just going back then. Okay, so the test we ordered was, we sent serology for Ehrlichia, but again, remember, it's the weekend, it was Saturday morning. Nothing is going to get sent out to the lab until Monday morning. Meantime, your patient is sick. What do?
Treatment.
What would you guys do? You treat it, right? You treat it empirically even when you don't have the diagnosis, because if you don't, these kids, they can have a bad outcome. The mortality is not very high, 1 to 3%, but they can become sicker. I have seen patients who ended up in the ICU. So if you suspect it, you treat it. The serology will take a week to come back. You don't wait for the confirmation, you just go ahead and treat it. And what is the treatment of choice? Doxycycline. Yes. So even though we always say don't use tetracyclines, doxycycline is a little bit safer, don't use tetracyclines in children below the age of 9. This is one condition, it's the first line treatment, it is safe to use. So, and now the Red Book, the new version of the Red Book actually says it's okay to use tetracyclines and doxycycline because it's only repeated courses of tetracyclines that cause staining of the teeth. Up to 5 courses have not shown any staining. So you use it. What you have to choose? Patient getting sick, stain the teeth. Which one are you going to choose? Of course, you want to make sure your patient doesn't get sick, right? So so we went ahead and started him on doxycycline just empirically. This is the serology that came back, so you can see it's positive, and he's still in the acute phase, but he has developed an IgG, so it's really getting into the second week of illness, and that's the reference range for our lab. IgM should be less than 1:20, and IgG should be less than 1:64. So, and of course you can see he's like clearly, there was no doubt about the diagnosis. But of course this did not come back. He was ready to go home. Or in fact, I think maybe he came back after he got home. So he did great. Next morning I came, different child. He responded very, very quickly. So, I think I just wanted to talk a little bit about tick-borne diseases that we see in the US, and like I said, we're probably going to see more in travelers here. I don't know if any of these ticks are endemic to Colombia or this part of the country.
We don't. We maybe have it, and we have it because there are some, especially with the veterinarians, they
see it for the dog tick, yeah.
So all those things, but
because they're all zoonotic infections. So I put the picture up there. I'm sorry.
That we have a Rocky Mountain fever.
Yes.
You do see Rocky Mountain
spotted fever. The rickettsial diseases in not only in Tobia. Tobia is a small town close to this Cundinamarca, the part state, but also we have in the coffee plantation area has been detected, and Ehrlichia has been detected in serology in soldiers that are going to those areas. The areas of the north of Colombia close to the Gulf of the Urabá, that is in Caribbean area, in Sucre and Córdoba, that are the states that we have it and has been tested by serology, and supposedly many of the cases maybe are missing.
They may be, especially children, may be asymptomatic. So many of them may have it, and sometimes we don't even know. Again, because it still presents this child came to us because of the abdominal pain, not so much anything else. So these are the three, there are lots of them, but to just make the discussion simpler, these are the three most common tick-borne illnesses that we see. So the black-legged tick, which is, I put pictures up there, the Axlodes scapularis, which causes Lyme disease, but can also cause babesiosis and anaplasmosis. And sometimes how you make the differentiation is from the part of the country where the case originated, right? Because these are not found all over the United States. So the Lone Star tick, which is what causes ehrlichiosis, is found in the central and southern parts of the United States. So that's why we think of ehrlichiosis. Anaplasmosis, which basically Anaplasma and Ehrlichia really come into the same family, but anaplasmosis is found in the north because the tick is found up in the north where you find Lyme disease. So up in New York, New Jersey, the Wisconsin, Milwaukee, those upper Midwest and northeast. So we have ehrlichiosis, we see tularemia, not so common in eastern but central, where they do more hunting. And then there's another thing we have, it's called STARI, sudden tick-associated rickettsial illness. Where they also present very similar to ehrlichiosis. So that's something else that we see. So that's what we see in the part of the country where I live. And then you have the American dog tick, which you can see there again. Obviously these ticks are very small. I mean, the Lyme disease tick, it is the size of a pinhead. So these are all magnified versions. So that's why most of the time nobody knows. That's the challenge. If someone comes to you with these symptoms and says, "Oh, here's the tick," then you don't need to be a genius to figure it out, right? But you don't see the ticks. Mostly, or the kids are playing outside. They come in, they shower, they brush off, the tick's gone, or sometimes it's very tiny. So that's why the pictures are nice, but you don't always see that. And then the dog tick, that's the one that causes the Rocky Mountain spotted fever. I actually saw a case when I was a fellow in Louisiana. So only case I've seen, because in the northeastern United States, we don't see this. This is where we are. If you go a little bit further up, North Carolina, South Carolina, yes, you see it. So these infectious diseases they just don't happen. There has to be certain risk factors, and I think that's what I teach my residents and fellows also, is you have to be thinking where somebody came from. Like, I think I don't know, you guys don't see malaria in Bogota, right?
No,
because we are up, but you see from the jungle. Same with us. We only see malaria, you're laughing, right? Because I said jungle. Sorry, my ignorance. But like in Florida, we don't see malaria. Even in South Florida, we have mosquitoes, so we see dengue once in a while, maybe some Zika, but it's not very common. It's only people traveling from outside who come and drink. So it's all very dependent on where you went, where you traveled, what vector you were exposed to. So those are the three most common ones. So this is the epidemiology for lichiosis, and this is where we are. I'll show you it. So this is where we are. Okay, this is where I live. So you don't see you just see a few cases, not so many, but I've seen maybe 4 or 5 now in the last 14 years or so, and confirmed cases, not suspect. These are all confirmed. Then this is anaplasmosis, just like I mentioned. So the vector, because it also carries Lyme disease, it's up in the northeast and upper Midwest. This is Rocky Mountain spotted fever, and so mostly you can see a few cases in Texas, but mostly this is Tennessee, North Carolina, South Carolina. This is North Carolina, South Carolina. This is Georgia, and this is Tennessee. This is Arkansas. So mostly in these areas.
Here in Louisiana.
Louisiana, yeah. See, so we were here. Martha, Travis, and we trained here. But this kid came from here. He was transferred to us. He came from this area. And he came down because, again, he got sicker. Everybody thought he had the flu, but he didn't have the flu, so he got sicker, and so then he was transferred down to Tulane. This is Lyme disease. Again, same, and you see all these cases in Florida. We don't really have Lyme disease. It's mostly cases that were acquired elsewhere, but were diagnosed in Florida. But mostly travelers from the north. Okay, so we talked about some of these things. So there's human monocytic ehrlichiosis and there's human granulocytic ehrlichiosis, which is now caused, basically anaplasmosis. And the difference is monocytic affects monocytes, granulocytic affects granulocytes. So that's the difference. So like I mentioned, it's mostly southeastern and south central. The lone star tick is the vector. And obviously we see it more in summer and more in males. Why do you think more in males? Because boys are more likely to go out and play in the woods, girls a little bit less likely, right? So that's why male, otherwise there's no genetic factor, it's just simply exposure. So the incubation is 1 to 2 weeks, so you may get a traveler who was exposed, they wasn't sick then, but now presents to you, was up there and now has come back home for summer vacation and, presents with these findings. Fever, so about 50 to 95% of them will have fever. Rash, 60%, more common in children as opposed to adults. So adults are less likely to present with the rash. And then non-specific symptoms, like I said, so looks like very much like a viral illness initially, headache, chills, myalgia, malaise. GI symptoms also, they may have, but not acute abdominal pain, right? So it's vomiting, maybe some diarrhea, just feeling sick, but not presenting as an acute abdomen. And then there may be some confusion, there may be CNS involvement. Our patient was not, so we didn't do an LP. But you may end up doing an LP, and you will see a CSF pleocytosis. And then conjunctival injection, which is typically non-purulent. And then these are the common, the triad like we talked about, which is, really this is what helps you make the diagnosis when the patient presents, not so much the clinical features, because they can be so non-specific. So this is the smear that Dr. Alvarez was talking about, and what the red arrow is pointing to what we call the morule. And that's usually present in the first week, but it's very non-specific finding, and it has to be a very experienced technician to see that. So what that is? It's just a group of bacteria. These are gram-negative cocci. So these are just clumps of bacteria that you will see in the monocyte. We have never seen this. Even the confirmed cases, because oftentimes by the time they come, it's usually end of the first week, second week of illness. So you would typically see, if you're going to see this, you're going to see this very early. And so the diagnosis is serology. PCR is sensitive, but again, if somebody gets treated, like for any PCR, the sensitivity decreases. And we don't really, PCR is not very widely available, mostly in the research setting. We don't typically send PCR, we usually send serology. And so you have to send a paired sample, IgG and IgM, because you just can't make, again, remember there's a lot of cross-reactivity between different rickettsial diseases. So you can't just make a diagnosis on one single sample. So you send paired. And ideally you do acute and convalescent. Our single titer was diagnostic, but sometimes if you have borderline results, you might want to do acute and convalescent. And then because IgG is also more reliable, so if you had a higher IgM in the beginning, when IgG was equivocal, but you repeat it, now your IgG is high, it's much more diagnostic. And then so 4-fold increase in IgG specific samples is diagnostic. So that's why you do paired samples. And so here are the diagnostic challenges, I think some of which we talked about. So first of all, the tick bite is painless. It doesn't hurt, you don't even know. The child will not tell you that I got bitten by something. And most people don't even remember that they were even bitten by a tick because they can't tell. And oftentimes, what's the first thing you do when you play outside and you come in the house? What do we tell our kids? Go take a shower. Take your clothes off and go. So even if there was a tick, you washed it off, right? And so you make a diagnosis on the clinical signs and symptoms, but the initial signs and symptoms, again, very non-specific. So then lab, you usually do a CBC, a CMP. CMP for us, which is a comprehensive metabolic panel, includes electrolytes and includes liver function tests. So that's where,
CBC?
Blood count. CBC is complete blood count, which is white count, platelets, hemoglobin. And then of course, like I mentioned, it can be fatal. So you do need to have a high index of suspicion in the right setting. Not somebody's influenza and they walk into your office and they've never been anywhere. They're not going to have tick-borne illness, right? And so like we talked about, doxy is the first line of treatment. Now, and it has better results. So you can use other agents that have been used. Trimethoprim sulfa can be used. Rifampin can be used, but these are not effective. So we really try to use doxycycline unless someone has a life-threatening, allergy, in which case you might try to desensitize them if possible, or start them on Bactrim, but monitor them carefully. Rifampin is, I think, better for anaplasma more than Ehrlichia. So again, that's why you won't see such good response. And then usually response is pretty good. In our patient, next day, I think he got discharged 2 days after we started doxycycline. Nice. And then we saw him in clinic and he looked great. About 10 days is sufficient. If very, very sick cases, sometimes you may expand up to 14 days, but usually 10 days. So once most symptoms improve, once you start treatment, and then basically there's never any set rule in ID for most things. Like you always say 7 to 10 days, 7 to 14 days, 10 to 14 days, and it really depends on clinical response. So in this situation, at least 3 days after the fever and symptoms have subsided, you want to continue treatment. I think we treated our patient for maybe 10 days, or 7 to 10 days, something like that. minimum you would treat is 5 days, and that would be, I guess, they came in really, really early, and it didn't really have any other systemic symptoms. Okay, that's it.
¿Alguna pregunta?
Any questions?
Muchas gracias. Pero preguntas, alguna duda, alguna cosa que no hayan entendido. Yo creo que todos entendieron bien. Esto es fácil. Solo voy a.
Yeah,
So we have a case report, no in kids, but in adult that was presented of the lichiosis with religious offenses. It was a 20. I think was like about 21 years old, was an adult patient that was presented in the Colombian Association of Infectious Diseases that we have here in the meetings are usually in Bogota. We have a monthly case, and you are invited to go every month, that adults and pediatric case. And it was presented a case like a soldier, I remember, that was with other in the north of Colombia, close to the Urabá area, and very woody area. And he was diagnosed with malaria first, and I think the others were also with malaria, and so the other improved, but he didn't improve.
Right. So that's a yes. If they don't improve when you're treating them for malaria, Kawasaki, or something, then
something else.
Yeah.
But he was having a rash and malaise, like flu-like illness, and leukopenia, hyponatremia, and leukopenia, and thrombocytopenia, and one of the IV, I think was in Medellin, he was transferred. They looked for. It was found positive the serology, and he was started. They also were thinking in leptospirosis, and we have more.
So we
here.
should use doxy for that too.
Doxy, and also exactly. So, and he had a liver function like transaminitis, and he was treated with doxy, and he improved very, very quickly. And after that, several, like 2 weeks after, they received the confirmation. So we have it. So we maybe treat with doxy because of Brucella, because of lepto, or something that is really.
So what we do is, whenever we have cases like this that are sort of atypical, and we're using maybe second or usually third generation cephalosporin for like sepsis or something, and they're not responding, or there's just something odd, we always start them on doxycycline.
Exactly.
Because it covers the tick-borne illnesses, it covers, like you said, leptospirosis, although we don't see leptospirosis except in travelers, and it also, would cover other atypicals, and also what we see in our area, because we are by the Atlantic Ocean, is a lot of Vibrio. So, right? So we have a lot of shellfish, and people, they get injured with fishing hooks and things like that. So Vibrio is also covered by doxy. So that's what when you don't, the patient is getting sicker and not improving with your traditional cephalosporin therapy, or maybe a macrolide if you're thinking of mycoplasma, then you just do doxycycline.
Exactly, doxycycline not to cover. Okay,
Thank you very much.
Yes.
How did that in this patient? Any hepatic failure or something like that?
They develop like sepsis, like shock. Although both Ehrlichia and anaplasma don't cause like intravascular hemolysis, just like Rocky Mountain scarlet fever is a vasculitis, right? These are not. But basically, they go on to develop like shock-like symptoms, and that's how they die.
So always, like my advice when we are in IV, we always cover bacterial. If it is very sick, like maybe meningococcus infection with a rash and fever and malaise and all these things, but also doxy if it's coming from an area that we think is not in Bogota, but maybe
outside.
De la tierra caliente. We always cover with for
We do the same. For us, somebody is coming from Georgia, I think it's very rural, right? Especially the part of Georgia next to Florida, because Atlanta is very further up in the north. So the lower parts, mostly rural, lots of woods, forests. People spend a lot of time outdoors. So especially summertime, a lot of tick-borne illnesses. Not so, starry is another one. When the serology, they may present with Ehrlichia-like symptoms. If you do the serology comes back negative, then it could be the starry. It's tick associated.
There are like many Colombians kids go to camping in the summertime
Outside
they go to the USA. Many like private schools.
So now you all look sick. Yeah. You all look so bright now, and you say, "Oh, but we're
Yeah. Which animals we can find the
sick?
Yeah.
The ticks. Well, it depends on. So for Lyme disease, it's like deer, right? And these are they're typically. I'm not sure it is
maybe,
or I mean, you may the ticks may just be found sort of independently, not necessarily in contact with specific animals. Like Lyme disease is usually like deer, etc. But these, I mean, they're just out in the woods, the ticks. So you can just acquire them directly.
Could be a cow, maybe? I don't know.
No, I don't. Rodents, some big rodents you can find like for tularemia.
Tularemia is cats, rabbits is most common, but cats, leptospirosis is more rodents, right? It's excreted in the urine. But this one, Ehrlichia, not specific. But could be carried by a dog or something, but there's no specific animal that I know of as associated with that. It's just playing outside and being exposed to the tick.
Which was good. Thank you very much.
Okay. So anyway, if you come to the US, you can call me. And I will take you around my hospital and introduce you to my resident.
Nuestros fellows, la de Silvia y